For patients and primary care listeners, what are realistic expectations for topical therapies like corticosteroids, vitamin D, analytes, things like that, in terms of efficacy and safety?
These medications, if used appropriately and in the right patient, can have very good to great outcomes. Again, with mild minimal disease in focal areas, using a combination of topical steroids with non-steroidal agents like vitamin D analogs can induce remission, and it can be used to control disease. Now, if a patient is using topical steroids on a very large surface area and it's not controlling symptoms, then that's the time to move on to another treatment.
How have biologic therapies transformed the treatment landscape from moderate to severe psoriasis, and what do clear to almost clear skin goals look like now?
The psoriasis treatment algorithm has evolved immensely, and it's wonderful what we have in our armamentarium of medications and options. We really can achieve clear to almost clear disease with the new, very targeted medications that we now have available.
Where do small oral molecules such as PDE4 and TYK2 inhibitors fit into your treatment algorithm, and which patient profiles are you thinking of when you prescribe them?
These are also a great option. I generally use them for my moderate disease patients who also may want to avoid injections or are a bit needle shy. The PD4s are great. Sometimes there's tolerability issues, but they can work very well for moderate disease. Um, and the other novel orals, they're also showing really great efficacy um in our bio-naive patients.
Mhm. Can you compare it at a high level the main biologic classes such as TNF alpha, IL-17, IL-23 along those lines in terms of efficacy, onset, and safety considerations that matter most in daily practice?
Yes. So we have many systemic agents. We have our conventional agents. Long ago, we would use prednisone. So we can think about oral prednisone as this big kind of umbrella medication that just stops all, um, inflammation in an immune driven pathophysiology. And then we start getting closer and we really start being able to target um, psoriasis in the pathways in psoriasis and the signals. So then we have our TNF, and that is again a little bit more broad treatment that will reduce inflammation. And then we have our very targeted IL-17, IL-23. These are biologic medications that are very targeted towards psoriasis, and because of this, we can see clear to almost clear skin efficacy.
Mhm. Interesting. How do you approach primary or secondary non response, and what is your strategy for switching within or between biologic classes?
This ends up being very individualized. I first like to get at is there a reason for uh, inefficiency or not being efficacious of a medication? Is the patient not using it properly? Are they adherent? Is there compliance with the medication? Um, so I really take it at baseline, and then I take it from there. If they're using it appropriately, maybe it's just not the right medication, or the body surface area is, for example, too great for a topical application. And then for secondary non-responders, we do see that sometimes, especially with the TNF alpha inhibitors, that sometimes there's resistance to those medications, and that can form over time. We can check antibody levels if they've produced an antibody that one of the TNFs is no longer efficacious for that patient. So there's different personal habits or reasons why a medication may not work. Sometimes it also could be, some of our medications are weight based. So there's the IL-12/23 medication. So if it's not appropriate for one's weight, we can change the dosage. We can also change the dosing schedule. For example, if a medication is If the typical dosing schedule is, every month, we can change it to every 2 weeks and see if that can be efficacious. Outside of that, we can then change the class as well if something's just not working for a patient.